come through the Q&A session. So without further ado, let's get into introducing our world-renowned speaker here, Dr. Rodney Taylor, Professor Taylor. His talk will focus on 2 decades of cardiac rehabilitation research and practice, a look forward and a look backwards. Dr. Taylor is a professor of population health research at the University of Glasgow. He's an honorary professor of health services research, the University of Exeter Medical School, and an adjunct professor in the Faculty of Health Sciences for the National Institute of Public Health and Department of Psychology at the University of South Denmark. So we'll likely find him in a few places over the course of his career, and likely the research he will speak to today. His former academic appointments include the London School of Hygiene and Tropical Medicine and the Universities of Birmingham and Exeter, and he was the first director of technology appraisals at the National Institute for Health and Care Excellence, NICE. He is a former National Institute Health Research senior investigator. So beyond those formidable titles that he holds in positions, he's published over 500 peer-reviewed articles. And for those of you in this area of research, you'll know that that is certainly no small feat to publish this many articles. What's even more impressive is that he has an H-index of 121 that speaks to the rigor of his research to date and also the interest in his work. Dr. Taylor's main research interests include the development and evaluation of secondary prevention and rehabilitation strategies for heart disease, hence why he was selected as our inaugural speaker here this afternoon. His interests also include clinical trial design and methodology, use of surrogate outcomes in clinical trials and reimbursement healthcare policy, and comparative effectiveness research for evaluation of medical devices. He is currently co-chief investigator for many ongoing research projects. We simply do not have the time today to list all of the trials which he's involved with or oversees. But I will further elaborate that he was involved in the development of the consort and spirit extensions for surrogate endpoints that you may use within your own research, and is the director for the Cardiac Rehabilitation Cochrane Review Center. So without further ado, I will open up this session to Dr. Taylor to take us away. Thank you.
Jennifer, thank you very much indeed for that very extensive and very complimentary introduction. And can I begin by congratulating you? Because I know that it's through your energy that you've managed to get what I believe this is, as you said, the inaugural first grand rounds for cardiac rehabilitation. So I think certainly a big clap in the room and a clap online to you for organising that. My only sadness is that I'm not with you in Ottawa, but of course the beauty of that is that, as we learned in the pandemic, we can be truly global. So it's great to know that not only do I have some people in the room with me today, and glad to see you've all got your coffee, and then secondly, we've also got some people online as well. So just great. So huge thanks again, and really is a privilege, Jennifer, to be able to give this presentation. So let me see if this professor can make his technology work. So let's see if I can get my slides up. So can I just check in the room that you're able to see my presentation okay and you're hearing me all right? Yep, good, okay. So as Jennifer was saying, I'm going to really do look forward and a look back. Just before I get going, just a couple of declarations of interest. So, and I guess this also speaks to my interest. So I'm a clinical trialist, as you've heard. I run trials in cardiac rehabilitation, but I also have the privilege of leading an international collaboration. You'll hear quite a lot about. We've generated a fair bit of evidence, which is the Cardiac Rehabilitation Cochrane Group. And of course, you know, if we don't have support from our funders, this isn't possible. So this is also just a nice opportunity for me to recognize some of the funding bodies that have helped underwrite some of this work, and also thank the many people that have been involved in this work that I'll be presenting today. So my presentation is really going to fall into 2 pieces. So the look back, I'm going to talk to you about the 4Ds, come back to that in a moment. And then if we've got some time, I would like to try and talk about, at least from my perspective, what I think are some of the big issues that are going to be facing cardiac rehabilitation and secondary prevention over the next couple of decades. So the 4Ds. So what are they? So I'm going to talk to you a little bit about, over the last 20 years, how we've gone about developing our evidence base. I think we've done an amazing job in this space. Let's see if I can convince you. Diversifying our population, talking about how I think evidence has helped driven policy and, importantly, practice. And I know from Jennifer speaking today that those of you in the room come from a variety, from the bench right the way through to the bedside. So hopefully we can span some of that. And then I think the other thing that has been really groovy, if I can put it that way, is our ability to pivot and develop alternative delivery models. And of course, COVID really accelerated that, but I think we can talk a little bit about the science that underpinned that too. And then, as I said, I'll finish up in the last 10 minutes or so talking about, I think, some of the important issues going forward. So that's the agenda. Maybe just a bit more about me. So as you heard from Jennifer, I had the pleasure of being at London School of Hygiene and Tropical Medicine. The reason I was there is I went back to university to be a statistician. So I am going to talk to you quite a lot about numbers. I hope it's not going to induce symptoms of dizziness and nausea, but really to try and underpin the science of cardiac rehabilitation. And also I'm going to be a little bit indulgent. So I am going to talk about quite a lot of the Cochrane reviews that I have been part of, and I should emphasize by not means being the only person in producing, but had the privilege of being involved in. So where did my journey in cardiac rehabilitation begin? Well, it actually began when I read these two papers. I suspect some of you may not even have been born in the room when these papers were published, but these were two citation classics, one led by a real legend and a close personal colleague, Neil Aldridge, and then the other from O'Connor from the US and Canada, respectively. Why was this such an important publication, or a pair of publications? And the answer was, it was the first time that a formal meta-analysis had been published in the peer review literature. And this is the forest plot that comes from the Aldridge review. Now, hopefully you can see this, but basically this is the outcome of all-cause mortality. And the important thing is that if we look at the pooled estimate at the bottom, we're dealing with a relative risk here. So these are trials that randomize patients to either get usual care or to get exercise or exercise-based rehab. And as I say, everybody was followed up and they recorded all-cause mortality. And if you look at all of the individual studies, you can see that the 95% confidence intervals, very wide, indicating these were relatively small trials, none of them individually showing superiority in this outcome. But actually, for the first time, when we put all of this evidence together, hopefully you can see from the pooled estimate at the bottom that actually we had an odds ratio of 0.8. And for the first time, that 95% confidence interval didn't cross 1. And therefore, we had evidence that there was statistical significant reduction in all-cause mortality as the result of patients receiving cardiac rehabilitation. And that was a real breakthrough, because if we think about that effect estimate, that was as big as things that we were doing at that time around drug therapy, such as beta blockade. So I think this really put cardiac rehab on the map, and it certainly stimulated my interest to get involved as a researcher. Of course, the world has highly evolved since then. This review, or the reviews I showed you, particularly focused on exercise-based interventions. We now know that cardiac rehab is so much more than this, as this graphic shows you. It really is a comprehensive program where I would put it, and as I do to my patients, that really issues of self-management are as important as their exercise program, as important as the behavioral gains that they might get through our mental health interventions. And I guess on the back of that, my first kind of contribution to the literature was this Cochrane review, which I did with one of my colleagues, Judy Jolliffe, who was a master's physio working with me at the time, which we published in 2001. And then we've had the pleasure of updating this Cochrane review a variety of times. We're now on version 4. This is the latest publication from the European Heart Journal, published in 2023, and led by one of my postdoc students, Grace Dibben. Now, why is it worth talking about these Cochrane reviews? Well, I'll put it to you that, and this is the infographic that we published alongside our review in the European Heart Journal, is just the first D, which is the development of evidence for cardiac rehabilitation. So when we went back to the Aldridge review, we had about 10 trials in about 4,500 patients. And as you can see, as we've updated the review in 2001, 11, 16, and 21, in 21, we've now evolved to 85 randomized controlled trials that have randomized almost 25,000 patients, which is an incredible evolution in our evidence base. And importantly, again, if you look at the outcomes in this infographic, we focused on mortality to begin with. We're now picking up not just all-cause mortality, but we're also importantly picking up outcomes such as hospitalization, which is a key cost driver, of course, in the space in which we do our clinical practice. The other thing that you can do when you have this large number of randomized controlled trials is to do some trial level methodology. So this is a bubble plot where you've got on the x-axis year of publication. The y-axis is the log of the relative risk. That's just to put it on a linear scale. But if hopefully you can pick this up. So the log of 1 is 0. So 0 is the null effect here. And can you see that if we plot the individual trials, the blobs of the trials, the size of the blob is effectively the sample size of the trial. You can see that there's a gradient over time, that it seems to be that whilst we were able to improve all-cause mortality in the 70s, early 80s, that effect is lost. So again, we can use these reviews to study these kind of level phenomena. And of course, what's going on here is not the fact that cardiac rehabilitation is losing its effect, but the change in standard of care over time. So things like thrombolysis, many of the drug treatments that we had available today weren't available in the early 70s. And therefore, prognostic benefit of cardiac rehab did expand there. But of course, the other thing that we've then been able to do is to evolve our evidence and bring in other outcomes. So this is our latest update. And of course, one of the main reasons that certainly patients in UK come to the cardiac rehab, not dissimilar across the globe, I'd put it to you, is not to lengthen the years of their life, but to improve the quality of those years. Quality of life, very key outcome. And this is just one forest plot from that review, looking at SF36, short form 36, generic quality of life. This is the physical component score, the mental component score. You can see pulling across trials. And in both cases, we've got evidence that cardiac rehabilitation against control, again, improves their quality of life. Now, sadly, one of the issues that this shows you, remember, we've got 58 trials now in this review, but actually not all of them by any means consistently measure quality of life. So again, you know, one of the messages is this is an outcome that we do need to try and more consistently collect in our evaluations going forward. And just to put quality of life on the map, this was the infographic that we published alongside our European Heart Journal review. And I think for the first time, you know, speaking to a very strongly clinical audience in this journal, not only were we selling the effects of the benefits potentially in terms of cardiovascular mortality and reduction in hospitalization and events I showed you earlier, but also the importance of rehabilitation as a tool to help improve health-related quality of life, and indeed an intervention that's cost-effective. So that's the situation in the coronary heart disease space. But of course, the other thing that's also happened in parallel is the evolution of evidence in another indication, one of the other Ds, the diversification of our population, which has been in heart failure. So this histogram summarizes the number of systematic reviews that have been published looking at rehabilitation in heart failure. And you can see it's an exponential growth over time. And the red boxes show you where we've come in terms of our Cochrane reviews. So our first Cochrane review, in this case, led by a young medical doctor, Ed Davis, and myself. We came in and there were 19 randomized controlled trials. And as of today, and in fact, we just got the acceptance for publication. Again, it just so happens from the European Heart Journal. Our 2023 version of this Cochrane review now 60 randomized controlled trials in 8,000 patients. Again, the same design, randomized to either receive exercise-based rehab plus standard of care or standard of care alone. And what's particularly impressive in this area, unlike coronary artery disease, is that we do have alignment in the way that we collect quality of life. So there's a lot of convergence in terms of disease-specific quality of life measures. So this is the Minnesota Living with Heart Failure scale. You can see that all of these trials have measured this outcome. I won't bore you with the stratification. We've stratified on the basis of risk of bias here, but the important result is, again, the blob at the bottom, which hopefully you can just about see. So there's a reduction in the Minnesota scale on average of about 7 points. And the lower the Minnesota, the better the quality of life. So this is obviously favoring exercise compared to control. And what's important about this result is that it's not just statistically significant, but it exceeds what we call the minimal clinical important difference, or MCID. So not only does cardiac rehab statistically improve your quality of life, but it does so at a level which is clinically meaningful for patients. Really important piece of evidence. So evidence, of course, can come in a variety of forms. And maybe just before I move on to my next slide, this is just to visit the fact now of where our Cochrane rehabilitation portfolio has got to. So this is not to say, oh, aren't we wonderful, but just to really show you the breadth of indications now that have been exposed to Cochrane reviews and exercise rehabilitation. And I know, speaking to an Ottawa audience, you've done a lot of trials in the AF space. So we're just about to publish that 2003 update, 19 randomized controlled trials and now over 2,000 patients. And also, we've tried to look at the question of service delivery. So for instance, if you break down the rehabilitation model, so psychological interventions, educational interventions, different ways of doing rehab, alternative models, we've got reviews in these areas. And again, just to flag for you Canadians, the last Cochrane review done in looking at uptake and adherence was led by Sherry Grace and our colleagues in Toronto. So these have been truly international endeavors where we brought together these teams to move forward the science of cardiac rehabilitation, which has been a great joy and a great privilege. So Rod, you can do all this work, but does it make a hill of beans? Does this really make a difference? Well, let's go back to one of the oldest clinical guidelines in our area. So this is one of the oldest guidelines I can find, which was the ACC-AHA guidelines for post-MI management. And this is the quote from that guideline back in 1996, where basically there was a sentence on rehabilitation. So the patient should be encouraged to participate in a formal rehab program and ultimately plan to engage in 20 minutes of exercise at blah, blah, blah. So that was it back in that day. But where has clinical guidelines got to now? Well, this is where we've got to with our evidence. This is what we're now driving. So this is the pair of clinical guidelines, most recently European and US. And you can see that in both cases, we've now got a class 1 level A recommendation for cardiac rehabilitation in this population. And of course, this is driven off what Jennifer referred to as our science in cardiac rehabilitation. And this cites our Cochrane reviews and various meta-analyses. And again, if we look at heart failure, we see the same picture now. So again, European Society of Cardiology, the American Heart Association guidelines, again, level 1 evidence that we should be providing cardiac rehabilitation to our patients. So I would put it to you that we have come an enormous distance in the last 20 years in terms of our evidence base, certainly for these 2 indications. So you could say, okay, well, let's just finish up here, Rod, and we'll just go back to the coffee and just have a chat. But unfortunately, life isn't so simple, because as my next slide shows you, access remains a problem. And I'll take the UK to begin with. So this is just looking at some of our audit data. And this is in the case of patients with heart failure who should be receiving cardiac rehabilitation. So back in 2019, 2020, about 5,000 patients with a diagnosis of heart failure were receiving rehab in UK. And that was about less than 1 in 10 of all patients with a diagnosis. Of course, that act of God came along and we had COVID. And you can see that that figure got even worse. Less than 5% of patients actually during the period 2020 were receiving rehabilitation. Of course, that was a hugely challenging period of time. But the other thing I want to do in this data is just reflect on the opportunity that that gave us to pivot from what was largely a center-based model that had traditionally come to the majority, almost 3/4 of people who did get rehab actually got a home-based program. So COVID gave us the opportunity to really push forward with alternative ways of delivering rehab to try and improve access. And just to update you, this is the 2023 audit data. And I think audit data is incredibly strong alongside our randomized controlled trial data. And actually, as of today, we've got somewhere around about 10% of our population receiving cardiac rehabilitation. So access certainly in UK remains a real challenge. And sadly, that's a global phenomena. So whether you look at the US, this publication, or whether you look to Europe or indeed yourself, I know this is rather an old publication from Sherry, but I think things probably still remain suboptimal in Canada as they do in UK. We really should have much higher levels of penetration in terms of our cardiac rehabilitation. Now, the reasons for that are obviously highly complex. And this slide is a characterization of a simplification of that. But I really like this slide because it kind of dilutes the problem down or dissects the problem down to 3 levels. We've got patient level barriers, we've got service level barriers, and we've got physician level barriers to cardiac rehab. But one of the things that I think cuts across all of these, and I've already mentioned it, is the need to consider alternative modes of delivering cardiac rehab. So getting out of that classic center or gym-based model that we might have been used to in the 70s, 80s, and 90s, and trying to take cardiac rehabilitation into the community, into the home, and onto the phones of our patients. So we in UK, no surprises, have been trying to push on. So this is one of the trials that I've had the privilege of being involved in. This is the CHARMS trial, where we randomize patients to either receive hospital or home-based cardiac rehab. So they were randomized to these 2 options. But we also allowed them, if they had a strong preference, to then actually get one of the 2 options. So this is what we call a comprehensive cohort design. And what we were really interested in is there a difference in our outcomes in the home-based setting compared to our traditional hospital-based model. And again, I'm not going to bore you with all of the detail of this slide, but this is just looking at 3 outcomes: the Hospital Anxiety Depression Scale, the McNew Quality of Life measure, and global well-being. And the important thing is that the p-value, both groups improved, and the p-value between hospital and home was non-significant. So whether we provided cardiac rehab for our post-MI patients in our home or in a center-based setting, and whether they chose the intervention or were randomized to it, made no odds of difference here. More recently, in 2010, we developed our first UK home-based program called REACH-HF. And we did a randomized control trial in patients with reduced ejection fraction. And this is the primary outcome, again, the Minnesota. And we randomized people to either receive REACH-HF plus standard of care or standard of care alone. And at 12 months, we found a statistically significant improvement in their Minnesota. Again, the mean exceeding that minimally important clinical difference we saw of 5 earlier on. And importantly, I think in a publicly funded healthcare system like you have in Canada, like we have in UK, we also have to demonstrate cost effectiveness. Our cost effectiveness willing to pay threshold is £20,000 per QALY in UK. So anything less than that, our national government, NICE, will fund. And you can see we had a cost per QALY here of under £2,000 per QALY. Highly cost effective. And of course, here's an alternative way of providing our rehabilitation programs for our patients, trying to improve that access. So one trial does not make a summer. So we can look at this across a number of trials. So what we've done here, this is from our most recent update, our Cochrane review of home versus center-based, our cardiac rehab for heart failure. And we've stratified the trials into either home, center, or hybrid, which is a combination of both. This is looking at the Minnesota Living with Heart Failure scale. And you can see, irrespective of whether you receive your rehab in either of these 3 modes, essentially your benefit is equivalent. And again, it's probably quite small for you, but if we do an interaction test to say, is the treatment effect across delivery mode, the answer here is a p-value of greater than 0.05. So in other words, we've got no evidence that delivering rehab in any alternative setting is any less beneficial than in any other setting. And if you don't believe that, this is our most recent center versus home-based cardiac rehab review published as a Cochrane Corner in Heart. This is led by one of my colleagues, Sinead McDonough in Exeter. In this case, we've got head-to-head, so we're randomizing patients to either receive home or center-based rehab. We don't have a lot of trials that have measured quality of life, sadly, in this setting, but we've got a lot that measure exercise capacity. And the message, the take-home message is the same. We have no statistically significant difference between the 2 modalities. Both improve your exercise capacity equivalently. Now, I'm not saying that we need to, every patient should be receiving home or center. We still need to think about risk stratification, but I think hopefully this evidence base that we can provide rehabilitation with consistent treatment effects across different delivering settings is very important in terms of our ability to go forward with our service. And again, although I've been less involved in them, there are many systematic reviews around tele-rehabilitation, again, showing that we can not only take the technology out of the hospital, but we can put it on patients' computers, we can put it on their phones, and again, achieve substantive improvements in outcomes. So again, is this really is the rubber hitting the road? So I just wanted to share with you a couple of guidelines from close to home, where not only are we now recommending cardiac rehab, but we're actually being able to say to policymakers, well, look, let's give a form of words where we can provide this rehabilitation in any setting. So this is just a quote from NICE. So offer exercise-based cardiac rehab to people with heart failure in a format and a setting that's easily accessible. Similarly, in Scotland, we've got the SIGN guidelines. And of course, Jennifer, thank you for sending over the most recent Canadian guidelines. I know you're updating these, but again, I read the messaging very, very similar here. We should be thinking about not just providing rehab, but trying to provide rehab in a setting that's appropriate to patients' preferences and also according to their level of risk. And this is maybe a little bit self-congratulatory. It's not meant to be this way, but this is just to show you now the penetration of our REACH HF program in UK. And each of these blobs shows you teams where we've actually trained up so that they're able to deliver this home-based program in UK. And this is from April of this year. So, you know, really a big change in the way in which we're now providing rehabilitation out of the hospital and into the community-based setting. Still challenging getting that uptake up, still only 10%, but at least we're now trying to give patients options. And this is just another slide to say that, well, when you spend lots of time developing interventions such as the REACH HF intervention, can we take these interventions into other international settings? As you heard, I have an adjunct professorship in Denmark. So one of my aspirations has been to take this intervention to Denmark. So we've done that now. We've translated the intervention. We've just completed phase 2. We've now translated and culturally adapted the intervention for Danes. Not that they're that different to Brits, but there are some cultural differences and there are differences in our healthcare systems. And we're just about to step into a pilot study where we're just going to check that this intervention is indeed acceptable and we can make this intervention available in a Danish healthcare setting as well. So that's the first bit of my presentation, which is to really look back. And I think, as you'll agree with me, we've made huge progress in terms of our evidence base around cardiac rehabilitation and the way in which we do cardiac rehabilitation. Good old Abraham Lincoln, best way to predict the future is to create it. So I want to talk to you about two pieces going forward, what I think are going to be particularly important that we need to be focusing on, whether we're in Canada, whether we're in UK, whether we're in Japan online. Let's see where we go. So the first of these issues is the area of multimorbidity. And for those of you who haven't come across this, and I'm sure most of you have, what we mean technically here is the coexistence of two or more chronic conditions in the same individual, this quote from WHO. And I particularly also like this graphic. So this graphic comes from an Academy of Science review of multimorbidity done in UK. And it importantly differentiates between multimorbidity and comorbidity. So comorbidity is a situation where you may present with, for instance, post-MI. You may also have other related conditions like hypertension. They would be comorbidities. You would be multimorbid if you have separate long-term conditions, such as, for instance, osteoarthritis or COPD. So comorbidities related diseases to the index disease, multimorbidity where we have standalone separate long-term conditions. And of course, as I'll show you in a minute, multimorbidity highly interacts with age. There is sex difference. And the other thing that does come out with multimorbidity, I won't have a lot of time to talk about it today, we can maybe pick it up in Q&A, is it is strongly related to patients' frailty as well. So this is just some data looking at your prevalence of multimorbidity, and you can see it really is a ski slope as one gets older. I think at my age, I should have on average a couple of long-term conditions, probably do. And in here, you've also got the Canadian data as well. And we're all following a very similar trend. And as, of course, our population ages, so the prevalence of multimorbidity is rising globally. And importantly, we are now beginning to develop an evidence base about just the negative impacts of not just having cardiac disease, but if you've got cardiac disease and you've also got a long-term condition alongside of it, really the negative impact of that is substantive. And what I want to do is to share with you some very early data. This data is just about to be published. It comes from the Perform program. I'll come back to the Perform program. This is a UK-led investment that we've recently had the privilege of leading. So this is using a large registry database in UK called SAIL, where we've got over 344,000 patients. And we looked at the question of, well, according to the number of long-term conditions you have, so 2, 3, 4, or more than 4, what happens to your risk of hospitalization or your risk of all-cause mortality? And you can see it's a really clear step function here, right? And then also, if you look at outcomes such as quality of life, and SAIL unfortunately didn't have the EQ5D. EQ5D, generic quality of life measure, where 0 is death, 1 is perfect health. We did the same analysis using the biobank data where everybody completed the EQ5D, again, almost 100,000 patients. And you can see that as you have, well, in this case, no multimorbidity, 2, 3, and 4, you can again see it's a very clear gradient where your quality of life diminishes. So I think one of our key challenges is not just dealing with our index cardiac condition, but also some of the other things that these patients will be presenting with as well. And I know that some of the audience today have got particular interests in areas such as diabetes mellitus. And indeed, on this theme, myself and one of my colleagues in UK, Professor Sally Singh, she's Professor of Physio at Leicester, she and I had this opportunity to present a commentary on really saying, look, let's nudge ourselves into this area. Isn't it time that we really took a multimorbidity approach in our approach both to cardiac rehab, which is my area, and Sally pulmonary rehab, which is her area. And as a result of that, we've now been able to do a little bit of work. So what I want to do, this is a bit of a busy plot, but again, it's a bubble plot where we've recently just done a review of reviews where we've looked at the question of, if you look at long-term conditions, and I think there was about 45 long-term conditions we included in this review, how strong is the evidence that exercise-based rehabilitation is beneficial for these individual long-term conditions? So the blobs, the size of the blob, so let's just take this one, coronary heart disease. The size of the blob are the number of systematic reviews. So coronary heart disease, there have been a number of systematic reviews of cardiac rehab. And the y-axis is the total number of patients who have been included in those reviews. So in this case, we probably, I think, got somewhere about a dozen randomized control trials and about 25,000 patients. And the x-axis is the important one, because what we've got here are long-term conditions where there was an evidence of a positive effect, those conditions that lie to the right, those conditions that are in the middle where there's an unclear effect, and then those long-term conditions where we have no evidence. And I guess what we can take from this is that there are a number of long-term conditions where we've got pretty good evidence that we should be intervening with exercise-based rehabilitation. But of course, here's the challenge. So I'm going to raise two challenges with you going forward. So the first is that certainly in UK, and I think it's not dissimilar in Canada, is that the way that we currently commission our rehabilitation is on the basis of single index long-term condition referral. So what do I mean by that? So in UK, you will only receive rehabilitation, cardiac rehabilitation, if you have a diagnosis of post-MI or acute coronary syndrome, revasc, or heart failure. And pulmonary rehabilitation if you've got COPD, bronchiectasis, etc. That's the way that we currently organize our service. But as I would put it to you, and as I've hopefully shown you with the previous slide, what we're doing as a result of that is excluding the referral of people with other long-term conditions who could potentially benefit from exercise. But of course, that throws up a huge challenge, doesn't it? How do we reorganize our service to provide what might be a more multi-morbid approach to the way in which we might be providing our rehabilitation services, as opposed to just a classic cardiopulmonary model that we followed in the past? And certainly in UK, I mean, I'm slightly overphrasing here, but, you know, is there a limited appetite to replicate services for additional long-term conditions? So for instance, as you'll see when we've updated the AF Cochrane review, we've got really strong evidence now that we should be prescribing cardiac rehab for long-term for AF, but would we really want to set up a separate service for AF? Or should we just see AF as another long-term condition that we should be weaving into a broader approach to the way in which we provide rehabilitation for people on the basis of whether they present with 2 or more long-term conditions? So let me just take that further. So this is a very nice analysis that comes from Andrew Farmer, published in the BMJ back in 2016. Busy plot, but let me just walk you through it. So let's imagine that we've got a couple of patients in front of us. So we've got a patient with coronary heart disease coming for rehab, or we've got a patient coming from heart failure. Now, what this shows is what their probability of having another long-term condition is. And you can see it's considerable. So patient with coronary heart disease are probably also going to present with hypertension. They may well have the AF, probably 1 in 5 chance of diabetes, and so on and so forth. And similarly for heart failure. So by definition, even although we are picking up single index condition, many of these patients are also presenting with these other conditions. So I would put it to you that this is our second challenge in this space, that although single index referral is our model, I think we're actually doing, you know, certainly I think our physios and our nurses think about rehabilitation in personalizing exercise prescription. But I would put it to you, are we really optimizing our exercise rehab practice to not treat the condition, but treat the patient, where we've got all of this complexity? And again, as I'll show you in a moment, certainly one of the challenges has been in reinventing our programs to be more explicitly considering the multi-morbidity needs of patients, rather than just the fact that they're post-MI, revasc, or heart failure. Now, okay, Rod, but is there any evidence to support this approach? Well, there is emerging evidence, and this is just a couple of systematic reviews that have been published. I'll just talk through one of them fairly quickly. So this is from the Danish group. So again, one of the challenges of these reviews is the way that they define multimorbidity. In this case, they defined it as 2 or more of the following conditions. But importantly, whether they looked at 6-minute walk test, whether they looked at quality of life, and whether they also looked at serious adverse events, the picture was very clear. There is supporting evidence, albeit these trials are small, and this was the conclusions of the reviewers, that we have evidence supporting, but low quality, but there's certainly good potential here. And on this basis, we've just been successful in UK in securing a large grant. This grant I mentioned to you earlier performed to specifically focus on developing a targeted multi-morbid intervention for our patient population. And we're just embarking on the pilot trial with the ambition of doing a full trial. This is a busy slide, but essentially we're going to randomize patients to either receive our multi-morbidity approach to cardiac rehabilitation, to the rehabilitation more generally, or usual care. And if they have a cardiac diagnosis, we are going to allow them to receive traditional cardiac rehab, but we will also compare them to a multi-morbid approach as well. And as I say, we're just beginning. We've done the intervention development and we're just starting off in our pilot phase. And we're very excited about this because we really think that this might be a very different way in which we will be providing rehab services going forward, assuming we can show an effect. My last challenge going forward is the global provision of cardiac rehab. And this is my last couple of slides. This, I think, is captured very nicely by this publication that came out, led by Sherry Grace and colleagues from Canada, where here we've got a map of the incidence of cardiac of ischemic heart disease across the globe, where red is high, green is low. And of course, the second slide that this analysis did was to then look at, well, what about the density of cardiac rehabilitation programs across the globe? And what this clearly shows is that in the global north, in North America, in Europe, we're very well provided for cardiac rehabilitation. But ironically, where our highest levels of ischemic heart disease exist, the levels of cardiac rehabilitation, as you can see, Asia, Africa, South America, very low, if not negligible. So we have this paradox of the prevalence of disease versus the availability of cardiac rehabilitation. And I think there's certainly an opportunity for us in the global north to be working with our colleagues in the global south to really try and move this forward. So this is a couple of editorials that I've been involved in a special issue we've just put out in the European Heart Journal. And again, I'm sure you'll be aware of the great work done by ICCPR in trying to move this agenda forward. Yes, we are now starting to move the dial. So this is a systematic review specifically focusing on evidence of trials in low and middle income countries. And some of you may be aware of the fact that there was this large randomized controlled trial published in JACC, done multi-center in India, where they use yoga as their means of cardiac rehab together with other self-management. And they were able to demonstrate an improvement in their co-primary outcome, which included quality of life. Very large trial and really probably one of the first large trials we've seen in this setting. So with the clock against me, I'm going to pull together just a few final comments, if I may. So as I've hopefully shown you, I think we have moved a tremendous way in the last couple of decades, huge evolution in our evidence base. And I think, you know, we have driven national, international clinical guidelines, practice and policy. And certainly in the case of acute coronary syndrome, post-MI, post-revasc, and in the area of heart failure, particularly reduced ejection heart failure, I think we are really established standard of care. And as we were able to pleasingly say in this European Heart Journal review, you know, cardiac rehab now is the fifth pillar of the treatment of heart failure. It's not just drugs, cardiologists. You should be referring your patients from the get-go to cardiac rehab. It's not a nice to have, it's a given. But of course, we still face a number of challenges. And if you want to read about these challenges, these are two lovely publications that look forward. And just to summarize some of the key points from there, as I've talked to you, I think this whole issue about equitable access, particularly in terms of global cardiac rehab, we have a responsibility to work with our global partners. We in UK are beginning to link up with South Asia in terms of our cardiac rehabilitation research going forward. We clearly need to think about implementing delivery models that are modern. We need to get out of a facility-based program. Yes, we need to think about stratifying our populations and identifying those populations, including multi-morbid populations, who are most going to benefit from our rehab. Perhaps not surprisingly, I remain a scientist, and we do need to collect clinical and other outcomes in this setting. But of course, as I've hopefully demonstrated to you, that doesn't just need to be randomized trials. It's also being able to using registers to monitor what might be on the ground real world practice. And then of course, we don't know what's going to be coming. So we've always got to be able to respond to future demands as they evolve over the next 2 decades. So thank you very much indeed for your attention. I will leave you with this quote from Mark Twain. Many researchers, many commentators have already thrown much darkness on this subject, and they'll probably continue. And I hope that I haven't thrown too much darkness on this one for you. But thanks again for your attention. I'm very happy to take any questions.
Thank you so much, Rod, for such a very clear and inspiring presentation. I think it was very well received from those virtual and in on-site here. Before we kick off the Q&A for a few questions, I want to remind those in person and virtual that in addition to having these inaugural rehab rounds, we actually are also having these interactive discussions with our speakers, and that's to facilitate greater interactions and collaborations and exchange of ideas. So I'm not sure if Research Services, Kelsey or AV is able to throw up this slide, but I'll say it just to remind everyone at 7 a.m. There is a session for those involved with cardiac rehab delivery. At 8 a.m., there is a session dedicated to faculty and researchers. And at 9 a.m., there's a session dedicated to trainees. These are open to everyone. If the time slot doesn't suit, we certainly can move you around, but it's to facilitate greater access and exchange with our speakers. So please do take advantage. The links are available, circulated by email and on Twitter. And I do hope to see you tomorrow at one of the sessions, where we will likely have coffee given the early hours of the discussion. So with that, I'm going to turn it over. We've got a question lined up in person, and then we'll attempt to navigate the online Q&A. So thank you, Rod.
My name is Peter Liu. I'm the Chief Scientific Officer here. And but thank you so much. It's just been a fantastic global overview, and particular tribute to you and folks like Jennifer in terms of being able to have the meticulously done clinical trials, and then meta-analysis to really have the evidence, right? That allows us to have the guidelines that influence practice, and so we can actually go forward and benefit patients. But I was particularly fascinated by your forward-looking pieces and in terms of multi-morbidity, because that's just the timing coming in that recently we received a major grant on brain and heart interaction and how we can actually, benefit the patient, because the patient tell us, I have these conditions, I have to see, different specialists, and I'm split into different ways. And and of course, I see on many of your diagrams, actually shows, importance, for example, of rehabilitation, in stroke, in multiple sclerosis, so many of these related conditions. Of course, things like cognitive impairment, very much are part of the profile of our patients, whether that's a heart failure or atrial fibrillation, for example. So I was fascinated by your PERFORM, program. And of course, going forward, I absolutely agree that we need to actually take this on a patient-centered basis, risk, a calibrated approach. and so that the rehabilitation, really actually has the maximum effect for the patient, at the same time avoiding duplication, right? Yeah, but I was fascinated, maybe you can just give us a little bit of illumination on the approach in which you try to address these multi-morbidity, because I really think this is the future, as we try to look after our aging population. Yeah, so just thank you so much, for that really forward-looking trial that you have.
Thanks, Peter, and great question. So yes, so I mean, I'll be honest. The development of the Perform intervention has been challenging. I guess the way that we've approached it is to build on our existing expertise from the cardiopulmonary side. So I think, exercise is medicine. So to some extent, the exercise piece of the intervention has been relatively straightforward, Peter. So our principles of exercise prescription, whether a patient presents post-MI, presents perhaps with Parkinson's disease, I mean, it really is broadly similar. Where the challenge in the intervention has been is in trying to think through the education and self-management around some of the other the other symptoms that may not be so classic in a cardiopulmonary setting. So for instance, if I said to you that one of the key drivers of low quality of life and multimorbidity is chronic pain. Yeah. So chronic pain. So what we've had to do is to write in modules around things that maybe we did talk about to our patients, but not to the same degree in a cardiopulmonary setting. So things like pain management, things like sleep, maybe also fatigue. Yep, fatigue was something that maybe came into heart failure. So I think we've had to think in a much more generic way, Peter, and ensure that we deliver the educational and self-management aspects so that, yeah, we deal with that broader population. The other challenge, which we're just beginning to face, is can we get clinicians to refer us the right patients? Because again, I don't know how it is for you in Canada, but actually having patients with multimorbidity being referred into rehab services is not something traditionally done here. People come in with single index. So again, trying to sort of reorganize our services. And we're doing this in 3 hospitals, Newcastle, Leicester, and actually a community setting, to see if we can test out the referral pathways to get the patients we need to go into the program. So it's been quite interesting. And I guess what I'm putting to you, it's quite, it really is something that is a challenging one for our healthcare systems of being able to do this well going forward. So I'll be very pleased, hopefully, to share over in the coming months some of that experience in the real world, but very early days for us. We've just developed that intervention.
We'll see. Yeah, I was just going to say that those are super thoughtful, but particularly relevant for the patient, and kind of resets our frame of mind. But look forward to opportunities for collaboration. This is super well aligned. Thank you so much.
Thank you.
So Rod, we do have quite a few questions in the chat system. Some of these I'm going to hopefully move to the sessions tomorrow morning, again, open for everyone. But I will just, if I can, cherry pick one question just given the time. So hopefully people can hold on for another minute or two. And I'm going to start off just with the very top, who's likely been waiting the last. This question comes from Anne Julian. That says, thank you so much for this presentation. Earlier in your studies, you included the diagram with the risk factor bubbles. Many are fundamentally in the hands of the patient to influence: physical activity, nutrition, stress management. Yet we don't tend to invest time in a discussion of strategies to support patients in changing behaviors for lasting impact. Do you see this becoming more likely as we build our understanding of the value and impact of cardiac rehabilitation?
Yeah, what a great question. What a great question. I must admit, I have changed my thinking about cardiac rehab. I'm going to out myself just for a second. So my undergraduate degree was in exercise physiology. So I'm a sports scientist. So getting in a gym, getting, sweaty, that was my modus operandi. But as I think I've worked with patients more and more, Jennifer, I realized that self-management piece and sustained self-management piece and how we do that effectively has been more important. So working with my health psychology colleagues for me has been a real revelation, because it's one thing getting that exercise message over, but it's many other behaviors and how we get into the psyche of the patient to make that doable within their busy everyday lives, and also sustainable beyond the period of time where we might be intervening with them formally. That's really where our challenge lies. But I think we've got some of the behavioral tools to do that. Our health psychologists have been about behavior change since the discipline was there. So yeah, great comment. I would totally support it. And we need to really focus on that comprehensive piece, right?
Mm-hmm, exactly. Well, thank you so much. I'm hoping the other questions that are on here, Quan Chan, they've posed a few excellent questions. Again, if you're not sure about the interactive discussions tomorrow, please feel free to send me a direct email and I can connect you. But I will try to summarize some of the descriptives, the adjectives that have been used for your talk this afternoon. And that is insightful, fascinating, erudite presentation. And so I can see from the comments flowing through the chat that this has been highly enjoyed by many, both in person and online. It's been insightful and has been clearly communicated and has given us a passion for where we need to move the needle in the future. So thank you so much. Enjoy the rest of your afternoon. We have a warm, sunny Ottawa here. I'm not sure the temperature in Glasgow today, but we will see you tomorrow morning for future discussions following our Q&A.
Thanks very much, Jennifer. And thanks everybody for attending both online and in person. Look forward to seeing you again.